Hi everyone, here is your content for burns and trauma. And as always, here are your readings. Really just one chapter in Lewis, chapter 24, page 431. So we're going to be going over just the different types of burns. That includes thermal, chemical, electrical, and also we'll be talking about some inhalation injuries. We're going to be talking about severity of burns and how to classify them. A little bit of pathophysiology, and also nursing management. Okay guys, so jumping right into this. So what is a burn? I'll let you think about that for a second. So it's injury to the skin or other tissues of the body. Okay, it can be from superficial, it can go all the way even into the deep muscle, depending on how severe the burn is. What can burns be caused by? It can be a source of heat, electrical, chemical, or even radiation. So really the result of injury is influenced by the temperature. So that's kind of more of from heat relating to a thermal type of burn, okay? And even the type of burn. So for example, a chemical or an electrical burn can also cause injury. And that's just influenced in a different way. Also think about the duration of contact and the type of tissue that is being injured as well. Also think about the age of the patient too. Other than the tissue injury, what are other concerns for the patient? What do you think, what else do you want to be concerned about as a nurse other than the tissue damage, whether it be superficial or deep muscle? What else should we be concerned about? Airway is huge, okay? Along with just the skin and tissue injury, we can also have smoke inhalation injuries as well. Okay, so really maintaining an open and patent airway and always assessing the need for a patient to need an airway is very, very important for the nurse. Adequate circulation. How is the patient perfusing? Really, we need to think about fluid and electrolyte imbalances as well. Will there be an infection? Malnutrition. So those are all just a few examples of other things that you should be thinking about as a nurse, other than the tissue damage or skin injuries from a burn. So about 3,000 patients die annually due to results of their burn injuries. Really, the highest fatality rates occur in children 4 years and younger, or adults over 65. So I just wanted to go over some common sources of hazards that can cause burns in patients. So starting off, hot water heaters. If they're set at 120 degrees or higher, that's a concern. Microwaved food, steam, hot grease or liquids from cooking, cigarettes, matches, and candles, heat lamps, fireplaces, open space heaters, using multiple extension cords, really even cement, if mixing cement, working with any chemicals, electricity from power lines, tar, steam pipes, radiation, and combustible fuels. And just to go over quickly, just some strategies to reduce burn injuries, okay? So these are kind of everyday things that we always need to keep in mind, especially thinking about children too. So storing chemicals safely, labeling containers clearly, We want to always ensure safety of really workers who work in fields that have a higher risk for burn injury. So wearing proper personal protective equipment, giving proper education to employees, always avoiding or repairing frayed wiring. We never want wires to be open or visible. Always shutting electrical power off if we were to do any repairs. Avoid any outdoor activities during lightning storms. Do not smoke in bed. Using child-resistant lighters. Practicing home fire exit drills is a big one. Never leaving candles unattended. Always using caution around microwavable foods and liquids. This one always really scares me with the little ones. Always installing up-to-date, smoke and carbon monoxide detectors. It's really important too these days. I know they specifically, I think, need to be hardwired, not only battery powered, but should be hardwired into your home. Using anti-scald devices on the shower head, faucet fixtures. Never leaving hot oils or grease unattended. And never, using flammables to start a fire. So just a few strategies, more education points to helping reducing burn injuries. So we're going to start off with the first type of burn here, and this is thermal burns. Okay, this one's kind of simple, and this is involving really our skin and the use of heat. Okay, so this use of heat can be from a flame, a flash, scald, contact with any hot object. Okay, it can be for a very brief, short period of time, and you can still get a pretty good burn, or it can be longer in duration, and I would think that would be a more severe burn. This is the most common type of burns patients experience. And again, like I said, severity depends on the temperature of the item that is hot, and also the contact time with whatever agent comes in contact with the skin or tissue. So just a picture of a thermal burn. Looks like a PD patient. I do have to share a story. It was a cousin of mine. He was, I think, 2, and his mother had taken out hot soup from the microwave. And this is just what always scares me with my little ones. I always try to be really good about this if I can, just putting hot objects out of the way. But unfortunately, this hot bowl of soup was kind of, right on the edge of the counter there. And of course, it just as babies do, they're curious. They go up and they grab the bowl of hot soup, and it just kind of spilled down his neck and his stomach. And he was in a pediatric ICU for quite some time, just because burns take so long to heal, and it's just such a process. So I just never forget that story, and I just never forget the safety of the little ones, for sure. Just another example of a thermal burn. And moving right along to chemical burns. So this is when your skin or tissues come in contact with either a chemical known as an acid, it can be an alkaline, or any organic compounds. And it causes skin damage, and pretty severe skin damage. Of course, always making sure that we keep our eyes in mind as well, especially working around chemical agents. It's really important to wear goggles. If that gets splashed up into the eye, it can be very damaging. Patients can even lose their eyesight. So acids, some examples of acids is hydrochloric acid, oxalic acid, and hydrofluoric acid. Some alkalines are known as cement, oven and drain cleaners, and heavy industrial cleaners. The alkaline burns are very, very hard to manage, more than acidic burns for sure. The alkaline adheres to the tissue, which causes protein hydrolysis and melting. So it actually just, it melts the skin. And then organic compounds, some examples of those are phenols, gasoline, and creosol. And an example of a chemical burn. This is an example of a hydrofluoric acid burn. And I think you can guess what this one is, which is it looks like the skin is melting away, but this is the alkali burn. So I want to talk about smoke and inhalation injury. It's a really important thing to factor in when we do get a patient who has gone through a situation of a burn. It's not always what we think. I mean, we think smoke inhalation, of course, like um, a fire with lots of smoke, but it can be actually, a patient who has breathed in noxious chemicals as well as hot air and, of course, smoke. So think of those three factors. Again, noxious chemicals, hot air, or smoke. Okay. So smoke inhalation injuries are a major predictor in the mortality of the patient. Okay. So this is why, as nurses, we need to be very, very prudent and always assess for a patent airway and open airway. Rapid assessment and ongoing critical assessment always needs to be done in burn patients. It's really a must. So why is this an emergency? Airway compromise, it's a big deal. The patient can lose their airway. So this is why we always need to be constantly assessing function of airway, doing that airway assessment very, very frequently. So airway compromise, pulmonary edema can develop very rapidly after a burn injury or a patient going through a traumatic event such as inhalation of like a chemical, steam, or smoke. So again, being very prudent on assessment. There is 3 types of smoke and inhalation injury, which we'll go over. There's metabolic asphyxiation, there's upper airway injury, as well as lower airway injury. Okay, so we're going to talk about metabolic asphyxiation first, okay? And this actually results from most deaths at a fire scene. Okay, so it's inhaling certain smoke elements such as carbon monoxide. I think you all have heard of that, and also hydrogen cyanide. So how does this consumption of smoke elements affect our bodies? So it's really oxygen delivery, and what happens when we inhale the smoke elements of carbon monoxide or hydrogen cyanide is our oxygen delivery becomes impaired to our tissues. Okay, so when we don't get oxygen to our tissues, what do we become? Severely hypoxic, right? So we have hypoxia going on. So again, just as a recap, oxygen delivery to our tissues is impaired, and the oxygen consumption to our tissues is impaired, okay? Our tissues are not gaining any oxygen, which leads to hypoxia in the patient. Death may occur, and this is a level we'll go over. It's called carboxyhemoglobin, and this is actually a mixture, so it's a hemoglobin combined with CO2. So death may occur if the carboxyhemoglobin blood levels are greater than 20%. Should we always assume the patient will always have burn injuries to the skin if we have any airway injury going on? No, they may not. A patient may not have any burn injuries, but have inhaled a lot of smoke. and that can actually be most detrimental to the patient, even more than a burn injury. So that's why it's always so important to do that rapid assessment of airway with any burn injury patient that we come across. And then we're going to jump to the upper airway injury. Okay, so this is really injury to the mouth, oropharynx, and the larynx. And it can be caused by a thermal burn itself, to the area around where we just mentioned the mouth, oropharynx, and the larynx, or it can be the inhalation of what we mentioned before, such as hot air, steam, or smoke. Okay, so we may notice redness to the area, such as the mouth, oropharynx, and larynx, blistering, edema or swelling. The patient may have copious secretions. They may develop hoarseness and difficulty swallowing. We really want to note for a stridor. Is the patient having any substernal or intercostal retractions? And also assessing again for any total airway obstruction, airway flow. We always want to maintain and assess that. So what happens, swelling can be massive, and the onset of this injury can be very, very rapid. So we really, really want to be careful with burns such as to the chest and neck. It can make for very difficulty breathing. When we do get severe burns, a lot of times what forms is eschar, and it makes the skin very, very tight and constricting, almost like a tourniquet. So if we do have skin that has been burned and it becomes very, very tight and constricted, do you think we're going to have good chest expansion? Or if in the neck, are we going to have severe swelling? Yeah, most definitely. Okay, so that's a major concern, especially with the areas and areas of thermal burns that are exactly around the mouth, oropharynx, larynx, neck, chest. Those are definitely areas we really want to be concerned with. So, edema and swelling is really the most lethal, as it's very, very obstructing to the airways. And do you think obstruction is an airway emergency? Yes, it most certainly is. And this is just the picture on the left-hand side is, examples of burns to the face. So you can see almost looks like that eschar material to the forehead. We have severe eye swelling, lip and tongue swelling. You can see almost charred around the nose, the nasal area. Severe facial edema. And then on the right hand side, it's actually showing a picture of the inside of your airway. And it looks like there's a lot of material that has been either charred or blackened from inhalation of smoke. And then we're going to move to lower airway injury. So this is airway injury to the trachea, the bronchioles, and alveoli. Okay, so a little bit deeper down. And we all know how important the alveoli are, right? Remember, in respiratory, the alveoli really are the main part of our lungs that, help with oxygen exchange and gas exchange. So if those have been injured, we're going to have really severe respiratory compromise. So this is again breathing in toxic chemicals, smoke, hot air, steam. And the tissue damage is again based off the duration to the exposure. So how long was it going on to either the chemical or smoke? And with this, we'll see a definite altered mental status. The carbonaceous sputum. So we saw that in that last picture, kind of where the airway almost looked charred. So that's kind of more known as the carbonaceous sputum, where it's blackened. The patient's going to be very dyspneic, short of breath. They will probably have some facial burns, singed nasal hairs, singed facial hair, that charred look to the face. They can have wheezing. And again, we need to always use caution or have that high suspicion if it is known that the patient was, trapped in a fire or in an enclosed space. Especially, if that is around the neck and chest. And why again? Why is the neck and chest a concern? They have severe burns to the neck and chest that can tighten, cause constriction, almost like a tourniquet. Be very, very hard for chest expansion. And of course, it causes severe edema, which causes constriction of the airway. With these lower airway injuries, we're also concerned with pulmonary edema. And this is a tricky one because pulmonary edema may not always appear until about 12 to 48 hours after the burn. So what do you think is really important as a nurse? That constant airway assessment, okay, in a burn patient, especially, you're not out of the woods yet. So, excuse me, we hit that 12 to 48 hour mark and we still need to be assessing airway. Always constant monitoring, constant assessment of airway is huge. Lower airway injuries can even manifest into ARDS, acute respiratory distress syndrome, and this is actually when the fluid collects in the alveoli. And you know what that will affect, and that is gas exchange. So again, just a few more examples of facial burns where we would be extremely concerned for either an upper or lower respiratory injury. Again, we can notice the carbonaceous sputum, again, the charred, blackened look. All right, moving on to electrical burns. Okay, so this is actually intense, intense, intense heat generated from an electrical current. There can be severe direct damage to nerves and vessels, which can cause tissue death. The severity really depends on the amount of voltage. Is there tissue resistance? Where did the current pathway follow through the body is a big deal. And also the surface area in contact with the current. So those are the four main things we always need to keep in mind with the severity of electrical burns. So tissue densities, also tissue resistance, there's different amounts of resistance to an electrical current, okay? Whether we're against a muscle or a bone, always something to think about of where the electrical current has passed through. So fat and bone is the most resistant. Nerves and blood vessels, very, very weak. They're the least resistant, okay? What tissues do you think is the most life-threatening for an electrical burn or an electrical current to pass through? Yeah, vital organs, brain, heart, kidneys, okay? Electrical burns are difficult as sometimes the damage is below the skin. We can't see it. So that's a tricky one. Continuing with electrical burns, so it's always important to determine the electrical contact points. So it's almost kind of similar to like a bullet wound. If you think of it, there's an entrance wound and an exit wound. And that can sometimes help us define where the current has passed through in the body to see what may have been affected. Okay. Contact with an electrical current can cause muscle contractions, which is almost strong enough to fracture long bones and vertebrae. Think about that one. And it's also very, very important to consider cervical spine injuries for all electrical burn patients, okay? Just because that electrical current can be so, so strong. What do we do for questionable cervical spine injuries? You guys know this. Yeah, neck immobilization, C-spine until things have been ruled out, okay? So it's always so important getting a history of the injury. It really can help us reveal, the path of the current that was taken. Again, assessing the entrance and exit wounds of the current, how long the duration of the electrical burn was to the patient as well. So we need to be aware of these things too. So dysrhythmias and cardiac arrest. So electrical shock can cause immediate heart standstill or VFib. Okay, that's a huge concern. Also, there can be delayed dysrhythmias and delayed arrest without warning in the first 24 hours. Okay, I want you guys to know that, and that's very important for nurses to know as well. The patient can actually develop a severe metabolic acidosis from an electrical burn. And then there's something called myoglobinuria. So this is massive muscle and blood vessel damage. Massive muscle and blood vessel damage. So the myoglobin from the injured muscle, it's released into the circulation, and it actually travels into the kidneys, and the size of the myoglobin can block the renal tubules. And if the renal tubules are blocked, what do we think is going to happen? Yeah, we get injury to our kidneys. Acute tubular necrosis is really what goes on in acute kidney injury. And these are just some examples of currents or entry and exit wound electrical burns. So more on the left-hand side, it looks like there was an entry through the hand and then an exit through the feet. And then on the picture on the right-hand side, it shows you full current there. It's unbelievable. So I just wanted to share with you, this is from the American Burn Association and how we do refer clients to burn centers. If they do rule in for this criteria, they need to be sent out to a burn center immediately. And that's where patients should be treated. So partial thickness burns greater than 10% of total body surface area. Burns that involve the face, hands, feet, genitalia, perineum, or major joints. Again, that's a lot involving airway too. Third-degree burns in any age group should be sent to a burn center. Any electrical burn, including lightning injuries, any chemical burns, any inhalation injuries. Burn injury in patients with pre-existing medical disorders, comorbidities that can really complicate management and prolong recovery, or even affect mortality rate. Any patients that have also other things going on from a possible trauma. So not only the burn is happening, but maybe they have had a fracture going on or another injury. And again, this is increased mortality rate. We need to send burn children especially to burn centers. And also patients who require maybe a little bit more emotional support, a little bit more special needs, or long-term rehabilitative interventions. So next we're just going to go over the classification of burn injuries. So we're going to look at the depth of a burn, the extent of the burn calculated. It's always in percentages, and we're always looking at the total body surface area, also known as TBSA. That's what that stands for. We always need to look at the location of the burn and also the risk factors. So what's the patient's age and what is their medical history? So I thought this was a really good slide because it kind of shows the two systems that we use for depths of burn. So if you look over on the left-hand side of this chart, it gives you both systems together. So I just want you guys to know this. So we have, if you go down along with me, we have first degree, second degree, a deep second degree, a third degree, and a fourth degree. Okay, so we have 5 depths here. So going along with that is a second system. So we're going, so superficial is a first degree burn. Superficial partial thickness is known as a superficial second degree burn. You can always remember that because superficial is in both words, so both types of systems. And then the third is we go to a deep partial thickness, also known as deep second degree. Again, the words match each other. We have full thickness burn, which is known as a third degree, and then we have a fourth degree burn. Okay. So please know the depths and the two systems in relation to them. And then I just want to go over the level of injury. So again, looking at the superficial or first degree burn, the injury is to the epidermis. And the epidermis will look typically dry, but it'll be red. It will blanch, and it's very painful. Typically, the healing time for this is 3 to 6 days, no scarring. So it's a minimal burn. So going down to our second is our superficial partial thickness, also known as superficial second degree. And the level of injury is now going down to the papillary dermis. So now we're going to start to see some blistering. So blisters becomes more moist and weepy, still blanches, and the patient has severe pain. So we do want to probably start to apply some topical agents to this. May need a sterile dressing applied. Healing time's a little bit higher, 7 to 21 days. Could possibly be a scarring. Typically, the patient will return to normal function. And then the third one, we go down to deep partial thickness, or also known as deep second degree. So the level of injury is to the reticular dermis, and most of the skin and appendages are destroyed. So with the features with this, again, it's blistering severely, and we're kind of getting more of that waxy look to the tissue. There is reduced blanching now. That's what kind of helps separate superficial second degree to a deep second degree. And they've also, there's now decreased pain sensation to touch. And why do you think that is? Yeah, we're losing some nerve. We've had some nerve damage now, okay? So we're not going to feel as much pain or pressure. So again, we'd want, topical agents. Again, probably a sterile dressing will be needed. This is going on to maybe possible grafting of the skin. That's how severe the tissue has been injured. Scarring will be common. May need possible excision of the injured skin. Debridement. And then going down to our fourth, which is our 3rd degree burn, also known as a full thickness burn. And the level of injury to this, the epidermis is destroyed, the dermis is destroyed, and all skin appendages are destroyed. Okay, so we just haven't gotten into the muscle yet. That's really the only difference here. So the tissue is going to look waxy white. It's going to look leathery. It's going to look inelastic. It's not going to blanch. There's going to be no pain, no sensation. We have total nerve damage. Possible pain to deep pressure. This patient's probably going to need surgical excision and debridement. Grafting will probably be needed. There will be some scarring. And then moving down to the 4th degree burn, which involves the muscle and bone fascia. And still, they may have some pain to very deep pressure in the area of the burn. In the surrounding areas, they will feel increased pain there as well. There'll be definite need for surgical intervention, definite need for grafting. So I want you guys to know the slide, okay? So really the American Burn Association, the reason why you need to know both systems, like superficial and 1st degree, it just helps with more precise classification according to the depth of the skin destruction, okay? And here is just an image of how the burn has entered the epidermis, and then we go to our superficial, and then we go to our deep partial thickness, our full thickness, and then the deep burn injury, okay? So it's showing you the epidermis, the dermis, subcutaneous, and the muscle. So next we're going to talk about the extent of the burns, and you may have heard of 2 common tools that help in determining total body surface area. Okay, so the first one we're just going to talk about is the Lund-Broder chart. This chart is considered to be more accurate. This one considers the patient's age in proportion to relative body area size. And then we have the rule of nines, which is often used for initial assessment. It's just an easier way to assess. It's not as accurate, they say, as a Lund-Broder, but it's a little bit more easier to remember, which is why it's probably used more for the initial assessment. So there's the Lund-Broder chart and the rule of nines, and I'll show you 2 pictures of those. Jillian on Monday is going to go over with you a little bit more in depth on the calculations of these 2 tools. Okay, I just wanted to give you a little introduction into the names of these and what they're used for and the look of each chart, and we're going to go over that in a minute. So just keep in mind that 1st degree burns, they're pretty much like equivalent to a sunburn. they're not included when calculating total body surface area. Also note that irregular odd-shaped burns or burns to the patient's hands are considered to be 1% total body surface area. And here is an example of the Lund-Browder chart. It breaks the patient down a little bit more concise and specific. And again, adding up these numbers depending on where the burn is on the patient's body helps you calculate the total body surface area. And again, you're going to go over that more a little bit on Monday with Jillian. And here is our rule of nines. As you can see, it's a little bit more easier. Of course, a little less involvement, but easier to understand for sure. Again, these percentages help you calculate the total body surface area of the burn. So I just want to talk about locations of burns and how they influence the severity or even mortality of the patient. Okay, so if we have burns, again, to the face, neck, chest, or back, what are we most concerned with? Yeah, inhalation injury is huge. And what else? Constriction, huge one. So we're going to have interference with breathing. Okay, so we're going to have obstruction from edema for sure. And then again, remember we talked about the eschar, the leathery tissue. It tightens, okay? When we get a burn so severe, it becomes leathery. We have the eschar, and it becomes like a tourniquet almost. So we're going to have constriction to breathing. We're not going to have good chest expansion at all. We're going to have severe edema. And again, these burns typically indicate inhalation injury. And then burns to the hands, feet, joints, and eyes. It can make self-care pretty difficult, and also it can jeopardize future functions. So burns to the hands and feet are very challenging to manage. Remember, superficial nerve supply always must be protected while the burns are healing. And then burns to the ears and nose. Patients can be at very high risk for infection due to the skin being very, very thin in these areas. And typically the underlying cartilage is exposed. Moving on to the buttocks and perineum, very high risk for infection, especially if the patient is incontinent of urine and feces contamination. And then there's circumferential burns, and these are mainly to the extremities, circumferencing the whole limb, okay? This is when we gain problems in circulation, okay? Excuse me. Excuse me, sorry. If you can remember this, circumferential and circulation, they kind of almost sound similar. Circumferential burns, patients develop circulation problems, especially distal to the burn. Very typical, we have nerve damage to the affected extremity or limb. And what can patients possibly develop from deep damage to muscle? If we have very, very severe burns, they've entered the muscle. We can have some compartment syndrome. So we'll have extreme edema, swelling. The patient can develop compartment syndrome. I want you to remember that. A little bit on age and risk factors. So we always need to keep in mind comorbidities, right? So does the patient have any pre-existing heart, lung, or kidney disease? It puts them at higher risk for mortality rate. Sometimes these patients have a poor prognosis. And of course, the recovery time's a little bit delayed. And extreme increased demands are placed on the body for patients with comorbidities or pre-existing diseases. I think you guys know this by now, especially what we talked about with our surgical content, but diabetes or PVD, the patient's going to have increased risk for delayed wound healing, okay, especially with the foot and leg burns. So we would expect to say delayed wound healing if we've had to decrease circulation or a history of diabetes. Risk factors as well. We want to keep in mind that, if a patient has suffered from any fractures, if this was a traumatic event, have they suffered any head injuries or any other trauma? Always need to rule out anything else. And increased age, 65 and above. It's a huge risk factor. So I wanted to talk about like pre-hospital and emergency care. So this is kind of care that's done in the field, kind of like more EMS type of care. So what's a priority? Once we arrive to the scene here, we really want to remove the burn victim away from whatever is the source of the burn, okay? Moving them to safety, especially keeping you safe too. If you're not safe, how can we care for the victim? We need to stop the burning on the victim if there is burning still going on to the body. And of course, like I said, get to a safe place, okay? I want you to know this, small thermal burns. So small thermal burns that are 10% or less of total body surface area, just cover them with a clean, cool, damp towel, cover the burn. And really cooling helps minimize the depth of injury. Okay, if we can get a cool damp towel over the burn as quick as we can, it's going to help minimize the injury to the burn. If the burn is large, okay, if it's more than 10% total body surface area, or if it's an electrical or inhalation injury, as well as the patient is suspected to be unresponsive, we need to initiate CAB, just like we kind of would with CPR. Remember, CPR is CAB. So we do circulation. So we're checking for a pulse. We're elevating the burn limb or limbs above the level of the heart. Airway, okay, checking for patency. What do we need to know, okay, around the airway or the face? Do we notice any soot, charring? Is there, charring or soot around the nose, around the oral cavity? Is there singed facial hair? Do we have burns to the face, the neck, the chest, the back? And then breathing, checking for ventilation, of course, right? And if the burn victim is responsive, we're going to flip it. So we're doing ABCs instead. So know the differences between unresponsive and responsive, please, okay? So if the patient is responsive, check in the airway first, going right to breathing, and then circulation. So it's really important to prevent any hypothermia to the patient. We want to cool large burns no more than 10 minutes. We don't want to make the patient hypothermic after everything else they're going through right now. It's really important also to not immerse the body in cold water. Why wouldn't we want to do that? It causes extensive heat loss, okay, and the patient, of course, will most likely become hypothermic. And should we cover the burn with ice? No. And again, hypothermia, extensive heat. So still talking about pre-hospital and emergency care in the field, really. We're now talking about chemical burns, and these are really best treated by quickly removing any of the chemical particles off from the skin or any powder from the skin as quickly as possible, removing all clothing containing chemicals off the body. The burning process will definitely continue if the chemicals are still in contact with the skin. So that's why it's so important to take whatever's in contact with the skin off. We really want to make sure to flush the affected area and irrigate the area from 20 minutes to 2 hours after exposure. So probably depending on what type of chemical it is, the duration the chemical was on the skin. Tap water is acceptable, even for flushing of eyes. Remember, we talked about chemicals can even be splashed in the eyes. And if we're flushing out the eyes, tap water is okay. Again, not only, I know we like to think about smoke a lot for inhalation injuries, but it can be a chemical cause as well. So inhalation injury patients really need to be watched carefully. You guys know why. Why is that? Respiratory distress, respiratory compromise. Definitely, it's, edema forms and causes constriction. We lose our airway. And if CO poisoning or carbon monoxide poisoning is suspected, it's very, very important to place the patient on 100% humidified O2, and that should be done right in the field, okay? And always consider trauma, okay? Did the patient fall? Is there any fractures? Do they have a head injury, cervical spine injury? So now we're getting into emergency management, okay? So we're going to talk about thermal burns, and we're going to talk about inhalation injury here. So again, if the patient's unresponsive, what do we want to do? CAB. Good. And if the patient is responsive, what do we want to do? ABC. Great job. So we need to assess for inhalation injury, okay? We're in the emergency room. Patient came in with a burn. What are we assessing for inhalation injury? What are we looking at on the patient? The burn location, right? Do they have burns to the face? Do they have burns to the neck, to the chest, to the back? Do their nares look singed? Is there edema to the mouth or tongue? Do they have a blackened sputum? Yep, that charred look around the face. Absolutely. Always providing oxygen is needed. Okay, we're assessing oxygen levels, providing oxygen. And what should we always anticipate if we suspect that there's an inhalation injury going on, or that, the chest burn or the back? So remember how that gets tight. What would we anticipate? Most likely intubation, okay? A lot of times providers like to play it safe and go through with the intubation before the patient has even entered respiratory distress. By that time, if the patient is entering respiratory distress, the edema may be so bad we cannot get an endotracheal tube down. So initiating that intubation earlier than later is always a good idea. Always monitoring level of consciousness, getting vital signs. What else do we want for air exchange or gas exchange? ABGs are always good to get. Carbon monoxide levels, getting that chest x-ray, CT scan. Removing any non-adherent clothing, okay, if that hasn't been done yet in the field. I know clothing that has been stuck onto the body, we wanna wait on that, especially in the field. Removing shoes, jewelry, contacts, glasses. If the total body surface area is more than 15%, the patient needs 2 large bore IVs. I want you to know that, okay? Need to start fluid replacement. Fluids are a big one in burn patients. We're going to want a Foley catheter in, especially if total body surface area is more than 15%. I want you to know that as well. And what do we want to elevate burn limbs? To what level? Yep, above level of the heart. Great job. Okay, so we're moving on. Now we're talking about electrical and chemical burns and what we're going to do when the patient comes to the ER. Okay, so we're kind of coming out of the field now and getting into the emergency management of things. So of course we've removed the patient from the source, and that's been done in the field, right? And we talked about doing that out in the field. We're again assessing for responsiveness or unresponsiveness and caring for the patient depending on which one they are. So if responsive, ABCs, right? And if the patient's unresponsive, yeah, we follow through with CAB, C-A-B. Yep. Identifying entrance and exit wounds. It's very important. Looking at the skin of the patient with an electrical burn, getting the entrance and exit wound is really important because it can help us kind of define the current that has traveled through the body and the location of the current. Obtaining ABGs is always important. And what do we want to monitor for electrical burns? There's 3 things we talked about. And cardiac arrest is a big one. Dysrhythmias is a big one. Yeah, and that myoglobinuria. So when there has been injury to the muscle, that myoglobin releases. And remember the acute tubular necrosis, acute kidney injury. The myoglobin gets stuck in the renal tubules, and that causes acute kidney injury, acute tubular necrosis. If the patient has had a chemical burn and they have actually dry chemicals on their skin, we need to brush those dry chemicals off before we do any irrigation whatsoever. If we continue to irrigate and the chemicals are still in the body, it's not doing any good to the patient whatsoever. It's causing more harm to the skin, more damage to the skin. Once any dry chemicals have been brushed off, of course, flush and irrigate chemicals from the skin as much as possible. We can do this to the eyes as well. Remember, tap water is okay for this. And if chemicals are in the eyes, we want to flush from the inner eye to the outer eye. We should always be contacting poison control with chemical burns. They give very great insight on how to care for patients like this. They have a whole protocol for chemicals for patients who have had chemical burns. So we would follow a lot of their recommendations. So next we're going to go into the phases of burn management. Okay, so we just talked about the field management. We just talked about emergency management. And now we're going to go into 3 more phases. So there's the emergent phase, also known as the resuscitative phase, the acute phase, also known as wound healing, and the rehabilitative phase, also known as restorative. Okay, so next we're moving on to the emergent phase. Okay, this is the time to try to resolve the immediate life-threatening problems that the patient is going through post-burn. And the emergent phase lasts up to 72 hours, so about 3 days. And the greatest initial threat to a patient with burn injuries airway, okay? And if they are unresponsive, we do CAB. Yeah, if they're responsive, ABCs. So during this emergent phase, we have a huge, massive shift of fluids. Okay, burn injuries cause massive shifts of fluid. And what happens is the fluid shifts out of the blood vessels, and this is due to increased capillary permeability, and it enters the interstitial space. Okay, this can begin as early as 20 minutes after a burn injury, depending on how severe the injury is. And what happens is water, sodium, plasma move into the interstitial spaces and out of the blood vessels, okay? So from the intravascular space into the interstitial space. So we have a lot of loss of proteins from the vascular space. Again, extensive fluid shifts from the vascular space into the interstitial space. This is also known as third spacing, okay? And this causes actually a lot of edema as well. Also during this emergent phase, we do have onset of probable hypovolemic shock and huge edema formation. And we know the emergence phase has probably ended once our fluid mobilization begins and the fluid shifts actually back into the vascular space. And that's pretty much when we know we have entered the next phase and the patient actually starts the diurese. But right now during the emergence phase, we have huge third spacing issues, edema issues, fluid is coming into the interstitial space from the vascular space. A lot of this causes hypovolemic shock in the patient. This is a great video. I only want you to watch it to 2:06, which we are going to do in class. So 2 minutes and 6 seconds. It's another good explanation just on the fluid shifts, the third spacing, and the electrolyte shifts in the body. And this is, I thought it was kind of the best picture I found here of what is going on. So what is happening here, if you look on the left, we have the fluid shifts during burn shock, okay? So during the severe burn, we have sodium coming out into the interstitial space. We have albumin coming out of the interstitial space. We have water, okay, which is all causing third spacing. It's causing edema. Potassium is actually coming out of the cell. And this is all from increased capillary permeability. So again, fluid components of the blood leak out into the interstitial, or also known as extracellular space, causing edema. What do you think happens to our blood volume when this happens? It's going to decrease. Yeah, we have fluid components coming out from our vascular, our vascular space. So yeah, our blood volume is going to certainly decrease, and our blood is going to become more viscous. So fluid is moving from, to areas that normally have minimal fluid. A lot of blister formation occurs. We have severe edema. We have actually severe weeping and drainage forming during this time. And again, this is what causes severe hypovolemic shock in burn patients, is this quick fluid shift, okay? What are signs of hypovolemic shock? Hypotension, good. Tachycardic. If hypovolemic shock is not corrected, Yeah, patient's going to die. It leads to death. So due to decreased blood volume, because the fluid is shifting out from the vascular space, what blood level would be elevated? Hematocrit. The hematocrit is going to be elevated in patients going through capillary leak during burn shock, okay? So after fluid balance has been restored and the fluid blood components return back into the vascular space, what lab value will return to normal? Again, the hematocrit. Yes, the hematocrit will turn back to normal. So as you notice here, like I mentioned, there's electrolyte shifts as well. So the potassium shift happens first, and actually the potassium leaves the cell in large amounts, and the sodium is entering the cell in large amounts. So potassium is leaving the cells in the extracellular space, and the sodium is entering the cells in the extracellular space. And if we look over on the right-hand side, this is when we know adequate fluid has been restored for a burn patient. As you can see, the sodium enters back into the intravascular volume, albumin, potassium moves back into the cell in the extracellular space, and water and sodium moves back into the intravascular volume. Once this happens, and we can tell this because diuresis starts to happen. So the patient is going to diurese in large amounts, and that's how we know we have normalized fluid shifts. Okay, the fluid is shifting back into the intravascular space. So I want to go over, clinical manifestations, signs and symptoms during the emergent phase. Remember, the emergent phase can be up to 72 hours. So again, we've mentioned hypovolemic shock, and why does this happen? Yeah, we have severe fluid shifts. So hypovolemic shock happens because fluid, sodium, is coming out of the intravascular volume into the extracellular space. It's causing third spacing. It's causing edema, okay? Patient presents like tachycardic, hypotensive. Great job. Burns at first may be painless, and why is that? We touched a little bit on that. Yeah, the nerve endings have been destroyed, okay? And this is especially if it's, deep partial thickness burns, full thickness burns. Remember that chart we looked at? Superficial to moderate partial, okay, are still painful, as the chart has stated. During this phase, we know a lot of blister formation. These blisters may be filled with protein. It's very common with partial thickness burns. We may notice a paralytic ileus. Patient may have decreased or no bowel sounds at all at that time. The patient can develop shivering due to heat loss. All could also be due to anxiety or pain. The patient may have altered mental status or be unconscious. This may be due to just the shock itself, or it can actually be due to hypoxia going on from smoke inhalation. So just a few things to think about of why the patient may be unconscious or have altered mental status. What would we need to do for this patient? Definitely assess CAB, okay? Circulation, airway, breathing. Possibly need ventilation, a ventilator, intubation, ventilation. Always constantly assessing the airway, patent airway. We're going to kind of break it down into systems now for this emergent phase, okay? So cardiovascular may have dysrhythmias going on, okay? The patient has gone through a very traumatic event. They may be going through a type of shock, especially hypovolemic shock due to the fluid shifts. What should be considered prior to vigorous fluid administration, okay? We do want pretty vigorous fluid administration, but what should we really look into in patients? Possible food overload, do they have CHF? Okay, so we need to really keep in mind their history as well. We don't want to overload them to cause cardiac compromise or pulmonary compromise. Patient will have increased risk for DVTs during this phase, especially, if they have increased age, obesity, lower extremity burns. Patients are at higher risk for DVTs or especially prolonged mobility. Circulation to the extremities may be impaired. And why is that? What type of burn typically impairs that? The circumferential limb burns. Yes, deep circumferential burns. So it really, just like very similar to the chest and back and neck burns that we say tighten, the same goes for the limb circumferential burns as well. Again, acting like a tourniquet, compromising circulation to the extremities. Okay. If this is untreated, what happens to our tissues and our extremities? Yeah, they'll be ischemic. Okay, we'll have necrosis, we'll have tissue death, ischemia, and necrosis. Not going to have any circulation, poor blood flow. What can be done with this? It's called an escharotomy, okay? This may be done to help restore circulation to the extremities and to improve chest expansion as well. So again, if we have the very, very severe burns, circumferential burns to either the limbs, chest, an escharotomy can be done to help with circulation and just to help with that tightening of the skin. And we have a little video on that we'll look at in class. And this is a picture of an escharotomy. And really we're releasing the tension on the skin to help with circulation. And I know it looks horrible, but this is what the provider will do. Then we're going into our respiratory system in the acute phase. So again, our main concern is smoke inhalation, upper airway injury, lower airway injury, and we're always assessing, patent airway, okay, in burn patients. And what are we looking for in these patients? Remember the level we need? It's the hemoglobin mixed with the CO2. Carboxyhemoglobin level is very, very important to get. What are we looking for on the body here? Yeah. Yes, charring around the nares, the mouth. Have the nasal hairs been singed? Do you notice any darkened sputum, blackened sputum? We want to do a respiratory assessment, right? So we're getting our patient's respiratory rate. Do we notice that they're, starting to use accessory muscle use? Are they getting tachypnic? How are their oxygen saturations? Are they getting more agitated? Are they having some altered mental status? Are they getting restless? What is immediate intervention if we do notice some respiratory compromise? Definitely intubation and ventilation. Yep. What can be a complication of inhalation injuries? Big one is pneumonia. Yep. Then we're moving on to our GU systems. So we talked about acute tubular necrosis, and why does that happen? The myoglobin released, myoglobinuria. So the myoglobin released from the muscles. And what type of burn injury is this from? Electrical injuries. Yes, electrical burns. So in response to the myoglobin releasing from the muscle injury, it blocks our renal tubules. It creates acute tubular necrosis, acute kidney injury. We're going to have decreased urine output for sure. We really want to, this is when fluid resuscitation helps our kidneys as well. Not only does it help with the fluid shifts in the body, but it can actually hopefully help reverse the obstruction in the tubules. Also, if the patient is going through that hypovolemic shock with the fluid shifts, there's going to be a decreased blood flow to the kidneys, again causing renal ischemia, decreased urine output. Okay. So nursing care for the emergent phase. So always doing that rapid, thorough assessment, especially the rapid, thorough airway assessment. Always, 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 always being prudent. Never really stopping on that airway assessment. Okay. Patients like this can be very, very unpredictable. They can change rapidly. They can develop airway edema suddenly. And that's why we need to always do constant assessments. Like I said, early intubation really helps remove the risk for any emergent need to even, sometimes you might not even get an airway in or endotracheal tube down just because of the severe intubation. This is when a patient, if we cannot get an endotracheal tube down the patient's trachea, we're going to need to do an emergent cricoid. And that's just not a pleasant thing to do. Also, nursing care during the emergent phase, the healthcare provider nurse will, of course, always make assessments on the depth and extent of the burns, like we talked about on the chart, okay? They'll go over probably the Lund-Bruder chart or the rule of nines and calculate total body surface area. We really need to figure out if the patient needs to be transferred to a burn center, but that's more with the emergent phase, okay? Once the patient gets out of the field, that's pretty much assessed right away if they need to go to a burn center or not. Airway assessment, like we talked about, is huge in management. Does the patient require intubation? If the patient is intubated, of course, they will need to be placed on a ventilator. And of course, the settings will match, the ABGs of the patient. Does the patient need an escharotomy? So are we having proper circulation to our limbs? Can the patient properly take full deep breaths? Is there no constriction when breathing? A bronchoscopy is always needed 6 to 12 hours after, to assess any lower airway if there has been smoke inhalation injury. And if the patient does not require intubation, it's always really important to give the patient 100% humidified O2 and place them in the high Fowler's position, so as tolerated if they can sit up as high as they can. We want to consider extubation once swelling has resolved. So typically, 3 to 6 days post-burn, unless noted otherwise. If the patient has had carbon monoxide inhalation or carbon monoxide poisoning, also it's very important to give the patient 100% humidified O2. Do you think, our normal SaO2, our FOX, is used for carbon monoxide poisoning? Do you think that would be accurate? Not at all. These patients with carbon monoxide poisoning, they'll have normal SpO2 readings. They'll have normal FOX readings. So patients who have had suspected carbon monoxide poisoning need to have a special carbon monoxide monitoring device. We're continuing here. So bronchodilators can be given, okay? Again, if we're dealing with smoke inhalation injury, bronchodilators open up the airway and they can be very helpful to prevent bronchospasm. We're obtaining IV access and we're getting at least two large bore IVs for 15% total body surface area or more. We need a central line if there is more than 30% total body surface area. Please know that. Know the 2 large bore, 15% total body, central line for 30 or more. We need fluid replacement, okay, because we know we're going to have fluid shifts. Severe burn patients, we're going to have extreme fluid shifts like we had talked about. Our sodium and water is going to come out into our extracellular space. We're going to have severe edema. Potassium is going to come out of the cell from the extracellular space. We need a crystalloid solution, and that is lactated ringers. Also, albumin is recommended as an infusion as well. So for the first 24 hours, we need a 2 to 4 ml of lactated ringers per kilogram per total body surface area. Please know that. Albumin is usually recommended 12 to 24 hours post-burn. Okay. IV fluids are always titrated based on the patient's response to urine output amounts. Electrical burn patients need an osmotic diuretic, actually, also known as mannitol. And we're looking for a 75 to 100 ml an hour output for these electrical burn patients. For just plain urine output for non-electrical burn patients, we want to see 0.5 mLs to 1 ml per kilogram an hour, okay, for output. So we need strict INOs for these patients. Blood pressures are really best read. An arterial line should be placed in burn patients. We want to start nutrition as soon as possible. Healing will be delayed if we do not. We know that good healing takes place with good nutrition. And we're managing the pain and anxiety of the patient. Just going back to the blood pressure readings and needing arterial lines, manual cuffs are just often invalid due to just so much edema and the vasoconstriction in the patient. So arterial lines are just, they're more accurate. Also on Monday, along with the total body surface area for like the rule of nines and the Lund-Browder chart, Jillian is going to go over more of an in-depth talk on the IV therapy and fluid administration with the lactated ringers. So just talking about some wound care during the emergence phase. So remember, emergence phase is 72 hours post-burn. So we really want to maintain cleansing of the burn. The patient may need gentle debridement. Extensive debridement is done in the OR. So there's the open method and the closed method for dressings. For the open method, the patient's burn is covered with a topical ointment and it's just left open to air. This is typically done with facial burns. The face can become very highly vascular and very swollen. So that's why we do not do a closed method dressing on facial burns. The closed method is typically done. This is when sterile gauze dressing is actually like impregnated with an antimicrobial topical ointment that's placed on top of the burn, and the sterile gauze is moistened with saline. These dressings need to be changed every 12 hours or once every 14 days, and that's dependent on the provider and the product that's being used. It's really important to prevent the patient from shivering and also keeping the room actually pretty warm. So we need to keep the room of a burn patient at least 85 degrees Fahrenheit. And also skin grafting can be an option. So this is also, all intertwined with wound care. Skin grafting can be actually taken from the patient's own skin, which we'll see a video of in a little bit. Can be taken from a cadaver. Also, neonatal foreskin can be used as well. During debridement, especially extensive debridement in the OR, necrotic skin is removed. When we remove necrotic skin, it just helps with granulation of the skin. It helps with epithelialization and healing of the skin. And that's why debridement is so important. Usually a once daily shower is recommended and a dressing change in the morning with an evening dressing change also. So that's very standard for burn centers. So a once daily shower in the morning with a dressing change and then an evening dressing change. Always using sterile gloves. We really want to prevent any infection or any, we don't want the patient to become septic or have any other issues such as infection. We always, if we do have burns pertaining to the face, We always need to just be careful of the eyes, especially when we have severe edema going on, when we're in this acute phase of swelling and edema. The edema can get so bad in the face that the eyes actually close shut and the patient cannot open them. So this is when we really need to provide ointment to the eyes, eye drops to the eyes, actually emotional support, because that can be very frightening to the patient. Always make sure that the eyelashes are not turned inwards. Make sure that they're outwards. We really want to make sure if the patient is incontinent that we do have a Foley in place, not only for strict I&Os, but just for cleanliness to the area, preventing any infection. Same thing if the patient is having a lot of stool and diarrhea, we would want a divergence for stool so the skin is not getting contaminated. So drug therapy during the emergent phase. So pain relief, right? So analgesics and sedatives. Typically, we're using the IV push route or an IV, such as a PCA. PO is just not quick enough at this time, at this phase. We're very acute, and they need relief quickly. IM is just not suitable due to the amount of edema and possible burns on the body. So we're using morphine, Dilaudid, fentanyl, Ativan, Versed. These are all very common for pain relief and sedatives. So morphine, Dilaudid, fentanyl, of course, would be pain relief, and then more sedatives would be Ativan and Versed. Tetanus immunization is really important. So, due to the risk of any anaerobic burn, wound contamination, if the patient has not received a tetanus shot in the past 10 years, they would need one. The patient should be on anticoagulants, especially to prevent any DVTs, right? Okay, it's probably gonna, we may be prolonged immobility for some time, or if we do have those circumferential limb burns, they're more at risk for blood clots. So we have Lovenox and heparin for that. And then nutrition, right? So vitamins. So the patient can receive zinc, iron, vitamins A, C, and E. These actually all promote cell integrity. They help hemoglobin formation and actually helps wound healing. Okay, so the emergence phase is done. Remember, emergence phase is the first 72 hours post-burn, and that's all the things we just talked about. And now we're moving into the acute phase. And if you remember, this begins with the mobilization of the extracellular fluid coming back into the intravascular space, and this means that we now have diuresis instead of edema, okay? So this phase ends when partial thickness wounds are healed and full thickness burns are covered by skin grafts. Okay, this can be weeks to months depending on the patient. The patient is going to be much less edematous at this point, and remember, we're going through that diuresis. The paralytic ileus is now gone. Bowel sounds should return. The necrotic tissue actually begins to slough off if it already hasn't been taken off with debridement, okay, and surgery. Full thickness burn wounds must have the eschar surgically removed or excised. Again, this helps with the epithelialization, granulation of skin to help heal. And after the eschar has been excised off, the skin graft should be applied for skin renewal and healing. So during this phase, we really want to be monitoring electrolytes, especially because we're having the fluid shifts back into the intravascular volume. So we want to make sure that we're staying on track with our electrolytes. The body is now trying to reestablish the fluid shifts. And of course, our electrolytes come along with that. Remember, our sodium is coming back into our intravascular space. Our potassium is going back into the cell. And so we're going to talk about hyponatremia. Okay, so that's low sodium, right? Other issues that can cause hyponatremia can be excess GI suctioning. Also, if the patient has diarrhea. Hyponatremia presents such as a headache, irritability, confusion, vomiting, and seizures. Hypernatremia, high sodium levels, not only with fluid shifts, but it can also occur after, excessive fluid resuscitation or tube feedings. The patient will present such as altered mental status. They present as drowsy, can be restless, have lethargy and confusion. And we want to restrict sodium, okay, if we do have a high sodium. If they're hyponatremic, we want to give things with sodium in it. Hyperkalemia, high potassium. So if we do have some renal failure going on, acute kidney injury, massive deep muscle tissue injury, remember from the electrical burns in the myoglobin, this can definitely cause hyperkalemia. Large amounts of K is released from damaged cells. So remember that potassium is coming out of the cells, especially when we have those fluid shifts. So we need to watch out for dysrhythmias, cardiac arrest. Patient may be confused, have muscle cramps and weakness. And then just the opposite, hypokalemia. So we have low potassium. This can be a cause from vomiting, diarrhea, prolonged GI suctioning. And also potassium actually can be lost through the burn wounds. So we'll notice the patient may have decreased reflexes, dysrhythmias, and decreased GI motility. And nursing care for the acute phase. We're going to continue to replace fluids as needed, but we're hoping the patient will be diuresing. But we're needing to monitor electrolytes while the patient is diuresing, making sure that they're not taking off too much fluid from their body. Continuing to monitor the strict I&Os, again, especially during diuresis. Like I said, monitoring lab values and electrolytes. Continuing that daily shower in the morning with the wound care, possible wound care again at night, continuing to debride as needed, adjusting wound care orders as needed. Especially as wounds heal, wound care orders will be adjusted. Observing for any skin infections, any sepsis going on, taking care of the grafting sites of the patient, continuing to assess and treat pain, helping with their anxiety, providing emotional support. It's really important to begin the physical therapy program. Continuing, range of motion. We want to prevent any contractures from happening. Also providing any anti-contracture devices, especially, preventing any foot drop that would be going on, providing any splints. The patient may need like boots or splints just to help with any contractures. Also range of motion helps with that as well. Continuing a diet that helps with the healing. Nutritional support. It can be by mouth, or if they cannot take anything by mouth yet, that can be enteral. Monitoring respiratory status still. Do they still need oxygenation needs? Monitoring for any signs of pneumonia, especially if they've had that upper or lower airway injury. Pneumonia can be a major effect from that. So we really need to monitor for that. For the nutritional support, really we want that high protein, high carb diet. If the patient has been intubated and now extubated, we also want to make sure that we do a swallow evaluation, just to make sure that the patient can take in PO. So a little bit on excision and grafting. Again, this happens a lot during the emergence phase and probably can continue into the acute phase. I just have a little video on that. This excision and grafting video actually shows a graft being taken from the patient's own skin. Very interesting video. So what happens is, the burn wound is excised down. So they cut off any necrotic tissue or eschar on the burn wound, and that helps with healing, granulation, epithelialization. And that burn wound bed is prepped first, okay? And the reason why it's prepped first is because the provider that's doing this needs to know how much skin they need to take off to graft that wound bed, okay? When surgical excision is done and they're prepping the wound bed and taking off the necrotic tissue and helping granulation begin, really creates a large amount of blood loss. Okay, so typically the provider will inject or put on a topical epinephrine, and it is done via an injection into the wound bed, and that really decreases bleeding while the procedure is going on. Once bleeding, has been decreased and the epinephrine has helped, the graft can be applied to the wound. Typically, they apply grafts by a sealant. They call it a fibrin sealant. Sometimes sutures, sometimes staples. To remove the patient's own skin, usually they take from the thigh, like the upper thigh area, and it's called a dermatome machine. And all it reminds me of is like a little cheese grater. It goes along the skin, it removes the skin. It can be either, depending on what type of dermatome the provider wants, it can be like a mesh type of look, or it can be unmeshed, such as like a sheet type of look. Really, a lot of times they'll do, if it's like a face, neck, or hand type of surgery, they'll do an unmeshed just for cosmetic looks. And now we've entered the last phase. So this is the rehabilitation phase. So this starts when the patient's wounds have really about healed, and the patient is actually starting to engage in their self-care. This can happen as early as 2 weeks, depending on, how bad the burn is for the patient, or it can start up till 8 months, again, depending on the extent of the burn. This is when we're helping the patient resume a functional role in society, and we're helping rehabilitate from cosmetic surgeries as well. So a lot of patients have to go through a lot of cosmetic, a lot of grafting surgeries, and we're helping them rehabilitate during these phases. During this phase, new healed skin may appear more pink color. It's not going to be the same color as their skin. It may appear even more flat, or it can be raised. It may depend on just the location of where the burn was, or, the size of the graft. Adequate range of motion needs to be performed, and this is really important. As the skin is healing, the skin's going to tighten, okay? And if the skin tightens without any range of motion or stretching, we're going to have almost like a contractured type of skin. And that's just, it's not going to be pleasant for the patient. So it's going to get to a point where the skin has healed, but if you haven't done the range of motion, it hasn't stretched. So it's going to cause like almost like a skin contracture. During this phase, cosmetic camouflage can be done. We can do pigmentation injections to the wound area or to the scarring, just to try to match the patient's skin as best as we can. Again, itching can occur as healing continues. If the itching is really, really bad, hydralazine, also known as Atarax, can be given to the patient. Also, just massage can be done. Cooling can sometimes help with itching. We really want to protect the healed burns from sunlight for at least 3 months, applying proper sunscreen if the patient is outside in the sun. And grafted areas are, most likely to be hyposensitive. So the nerves are still regenerating at this point. They haven't totally came back yet. So still hyposensitive, still lower, pain tolerance to that area due to the nerve damage. And this is just, what we were just talking about. Hypertrophic scarring can happen, raised scars. The patient may develop joint contractures and also skin contractures, like we were talking about. So that proper range of motion is really a big deal. As the skin is healing, we need to be stretching it at the same time. And then nursing care for the rehabilitation phase, okay? So it's more emotional support and education than anything. So we're encouraging the patient and family to take part in their care as much as they can. If going home with any unhealed wounds still, we need to provide education on wound care, how often it should be done, and before they leave, we need to see them properly place a dressing on the wound bed. Again, have the patient demonstrate how they would care for the wound, and educate the patient on signs and symptoms of infection. If they do still have an unhealed wound, it's really important for the patient to know that. Case management can always help arrange with, if the patient would need any visiting nurse, any help at home, if they need to go to a long-term care facility for a little bit. Educating the patient on scar management. And what would you educate this patient on scar management? Yeah, the sunlight, staying out of the sun for at least 3 months, providing sunscreen. If it's very itchy, they can do massage, cooling, hydralazine, continuing range of motion, continuing with their PT/OT routines, and really most important, emotional support. Why do we want to do that? Patient can be going through a lot, and at this point, they can develop all these signs. So they may be angry. Why did this happen to me? Will I look normal again? They can be depressed. They can have a lot of guilt of what happened to them. So again, a lot of emotional support during this rehabilitation phase. And this is the end of your voiceover for burns. I hope this has helped you. If you do have any further questions, always email me. I'm totally welcome to any questions or emails. And thank you very much.